And I think you're able to see my slides. So just wanted to kind of go over, what it is. Yeah, Dr. Aswarn talked about, what the multidisciplinary team does. And I wanted to show you from a surgeon's perspective, how important that multidisciplinary discussion is. And even, from one of the members of the team, how we really rely on the assessment of everyone else. So the things that I'll be talking about in terms of surgery for liver tumors are, just kind of go over why it is that we cut parts of the liver out or the whole liver out, what we do before the operation, some things about what we do during the operation, and some of the new developments. In terms of what we do or who we operate on or what we operate for, really, the reason to cut parts of the liver out is that if there's anything in the liver that's not clearly benign, we really need to think that it's malignant, especially in people who have a predisposition to liver cancer, who are getting screened, we get more suspicious. Now, the most common tumor in the liver that is not coming from outside the liver is hepatocellular carcinoma, but there are also more rare tumors like tumors of the bile duct or the gallbladder. And the other reasons that we actually cut parts of the liver out is if there are tumors that came from outside of the liver, and there are very specific questions that we have to ask about those patients with colon cancer metastases or other kinds of tumors, and I'm not going to get into that right now. Other reasons that we cut, we operate on the liver if there is benign disease that's really causing symptoms, but only if it's causing symptoms or if there's some concern for cancer, like the rare cases where a benign thing can actually be concerning for a cancer. Some of the other benign reasons we operate on the liver would be things like adenomas, some of which, depending on their size or their characteristics, can either rupture and bleed or develop into tumors. But really, I'm going to skip through a lot of that stuff because we're talking about liver cancer and talk about when I see someone in my clinic or we discuss someone at a tumor board for surgery or for any kind of liver cancer, what we think about before operating on them. So most importantly is, how are they medically? What are their medical comorbidities? How are their hearts and lungs and general liver function? How bad is their liver disease? And if there are questions about that, we really rely on our hepatologists as well as our interventional radiologists to give us an idea of that. Sometimes we'll do a biopsy. Sometimes we'll just, a scan is enough. Certainly labs are going to be part of it. And in some cases, we actually do functional tests. The other thing that the surgeon does with the help of radiologists is, where is the tumor? Is it very central? Is it right on the blood vessels? How clean are the margins going to be when we cut it out? What is our expected margin? How much liver is going to be left over as we cut it out? And sometimes it actually takes sticking a laparoscope in the abdomen to get an idea of these things because, although everything is getting much, much better, sometimes there's a need for actual sort of eyes on the liver itself or eyes on the rest of the abdomen. So who do we decide not to operate on? Well, if they have severe functional liver disease, so child class C patients, this is kind of a classification that's based on how functionally ill patients are based on their bilirubins and their ascites and their nutritional status and their coagulopathy. That's going to be an important thing. As well as, how much liver is going to be left over, how much, medical comorbidities they have. And there's this score called the MELD score that's based on labs that we look at. And so it's a balance between how much liver we're going to take and how much liver and total sort of disease they have. The more liver we take, the less comorbidities they can have. In patients with totally normal livers, we can leave up to, we can leave down to 20% of liver. We can take 4/5 of the liver if the liver is totally normal. Now, it's very rare that a liver that is totally normal has HCC in it. So a lot of times the patients will have fatty liver or more cirrhosis or fibrosis, in which case we can take less and less. There are some things that we can do if there are issues with with the liver, just in terms of, if there's too little volume left over, we can get what's called hypertrophy. So we can make the part of the liver that's going to stay get bigger. And I'll get into that a little bit. So other things that we would actually do a liver biopsy if there was a question. Sometimes we'll do functional measurements. We'll definitely check a MELD score because a higher MELD leads to poor outcomes. We look at the general status of the patient. We look at the tumor. So, big tumors, ruptured tumors are still okay for resection, meaning that, they're not acceptable for transplantation because we worry about recurrence after transplantation on immunosuppression. But I think with a resection, we're still more likely to consider that. And then there are cases in which the tumor is associated with what's called a tumor thrombus. So tumor actually being in the large blood vessels. So if there's tumor in the blood vessels, that's not acceptable for liver transplantation because that's associated with super high recurrence rates after liver transplantation. But if we can cut it out and include the vessel that has the tumor in it, it's possible to get favorable results. So how do we figure those things out? Well, we do CAT scans or we do MRIs. And what that helps us to do is to get an idea of where the tumors are, what the blood vessel status is, and whatnot. So this basically, what happens when either the tumor is too big or the remaining liver is going to be too small? Well, so in patients who don't have enough liver volume that would be left over, what we can do is have our radiologist do what's called a portal vein embolization. So getting them to basically stick a needle in and put a coil into the part of the liver that's going to come out. Well, what that does is it cuts the blood flow to that part of the liver. It increases the blood flow to the part of the liver that's going to stay, and that part of the liver that's going to stay gets bigger. And not only does that mean that you have more liver after the operation, but it's also kind of like a pretest. If the liver is good enough to grow with a PVE, with a portal vein embolization, it means that liver can tolerate an operation. A little bit more, recently, what we've been doing is that we've also been doing this Y90 embolization. So these are radioactive beads that get put in instead of just the coils that get put into the blood vessels. So not only is the tumor being treated, but the area around the liver is getting treated. So it kind of gives the same effect in terms of getting the part of the liver that's going to stay bigger. People, often ask me, just a little bit more details about the surgery, what we actually do. So I'm going to go over some of the operative principles, but this isn't to actually go over the specific details of it. So what's the treatment goal with any kind of surgery in liver cancer? Well, the goal is to remove all of the tumor cells and get clean margins, right? That's goal one. Parallel, though, is goal two, which is we need to leave as much liver as we can so that the liver that's staying there will function and to minimize any kind of liver failure risk after that. And of course, overall, everyone, the ultimate goal is to prolong life and to increase the quality of life. To get to that, what we like to do is do what's called an anatomic resection. So maybe a small tumor, but really coring it out isn't the answer, because if we actually remove the anatomic section with the blood vessels going in and out of it, it's been shown to improve long-term results. But that said, it doesn't really matter how big the margins are as long as the margins are negative. Now, with some unclear tumors, for some central tumors, bigger margins are better because, as I'll get to a little bit later, the liver cancer is one of those things where just because we cut a tumor out doesn't mean that other parts of the liver won't develop tumors. So this is a question. So, and then people will ask me, well, on the one hand, when I decide, or when the team decides liver transplant's the answer, why transplant and not cutting it out, and vice versa. And so we'll go over some of the arguments for and against liver resection versus liver transplant. So why would we not want to do surgery in terms of cutting part of the liver out? Well, so what it does is that cutting part of the liver out takes care of the tumor that we see in that area. That's basically what we call the local control of that tumor. The problem, though, is that most of the time, it's the entire liver that's the problem. So the entire liver is affected by whatever disease it is that's causing the cancer in the first place. Now, in the era before all these great Hep C drugs, when we just cut out tumors in patients with Hep C, up to 90% of patients had another tumor somewhere else in the liver. We're not talking about a margin that wasn't clear. We're talking about somewhere else in the liver within 5 years. So the liver is the problem, not the tumor. And there are also cases when we decide not to cut the liver out or transplant where non-surgical methods have the same survival, meaning that there may be increased local recurrence, but in patients who are really sick, the morbidity mortality overall can actually be lower with an ablation or a Y90 or some other thing like or radiation or something like that. Because ultimately the survival depends on the underlying liver disease, not necessarily the specific tumor. And who are some other patients that we can't operate on? Well, unfortunately, of the patients that we all see for the first time with liver cancer, more than 70% of them can't have an operation. It's because either they have tumor outside the liver, or they have multiple tumors in both sides of the liver, or the bile ducts are involved very centrally, or there's tumor in the big veins. So this is why screening is important. This is why anyone with cirrhosis needs to be screened. This is why it's a team, it's a team involvement here. And so, we try, the best offense is a good defense, right? So preventing people from developing cancer is the best. And so why does that push us towards doing transplantation? Well, transplantation is potentially curative, not just for HCC, but the underlying liver disease. And for anyone who has decompensated cirrhosis, it's the best treatment option. So it's recommended for people who are within what's called the Milan criteria. And the Milan criteria is what you'll hear about a lot in terms of the size and number of tumors and whether, transplantation is recommended or not recommended. So the Milan criteria means if you have liver cancer and it's one tumor, that one tumor can't be bigger than 5 centimeters, so about 2 inches in diameter. If you have more than one, you can have up to 3, but none of them can be bigger than 3 centimeters. And you can't have any disease outside of the liver, any cancer outside the liver, and no major blood vessels can be involved. Now, it's possible to, if you start outside those criteria, to get you within criteria with either ablation or with Y90 or with external beam or whatnot, as long as at some point you get inside the criteria and you stay within those criteria, then transplantation becomes an option. And patients do very well. 5-year survival with transplantation, given these, is really good. I put 75% here. It's probably a little, even a little bit higher than that. And tumor recurrence rates are very, very low. So this is great. So, I told you this transplantation is great. Now, why would you not want to transplant some people? Well, there are some people who have liver cancer who don't actually end up having liver disease that is really bad. And so that would be the treatment of choice, because why is that? Well, transplantation is a whole thing, right? And you'll have to be on immunosuppression for the rest of your life. And, it's a bigger risk operation than cutting a part of the liver out. And so in these patients who don't need a liver transplant, it's not indicated. And then there are patients that, they're larger, so we can't get them within criteria. And there's a problem with them with like injecting them or ablating them. And so, we can't transplant those patients, but we can operate on them. And then there are some older patients that are not transplant candidates because they have comorbidities that are too much for liver transplantation, but not for liver resection or liver, cutting that part of the tumor out. And then, of course, there's the limitations that we're left with in terms of organ availability. So that becomes a major issue. For, patients who have multifocal tumors, never really are candidates for liver resection because we can't ever cut enough of the liver out without transplanting it. But when there are, when the tumors are too big for transplant, they're not necessarily too big for liver resection. Vascular invasion, I told you if there are tumors in the big blood vessels, transplantation is not an option because of the recurrence rate. But resection, I think that that's certainly a possibility because you don't have to be on immunosuppression. One of the reasons would be because you don't have to be on immunosuppression for the rest of your life, and immunosuppression increases, cancer growth. So what do we do? What are the surgical options? Well, we start with, what's our approach? Well, generally, most surgeons start with putting a camera in the abdomen just to make sure there are no surprises. Then we look around the abdomen. We do an ultrasound of the liver to make sure that the tumor is what we think it is. I always use what's called perfusion imaging just to get an idea of the blood flow to the liver, of the anatomy, as well as where the tumor is, and I'll show you some pictures as to what that means. Evaluate the cirrhosis and the anatomy, and if there is any evidence of disease outside or anything looks funny outside the liver, we'll biopsy those. And then what's the sort of the spectrum of operations that we do? We do what's called a wedge resection, so just a small resection. If it's a very, hanging out on the edge kind of tumor, a small tumor. We'll do a segmentectomy, so liver has, depending on who you ask, 8 or 9 segments. We'll just remove one of them, or we cut out either the right side or the left side, or a little bit more than the right side, or a little bit more than the left side. Sometimes there are tumors that are kind of stuck in the middle or smack dab in the middle. So we'll have to do what's called a parenchymal sparing, like a middle hepatectomy. And very, very, very rarely, with someone who is at a transplant center, who's got a lot of experience with these things, we can actually cut the whole liver out, do the resection while the liver is outside the body, and then sew it back in. So this is kind of like what a left hepatectomy looks like. You see the arrow as to where the left side comes out. We'll cut through the liver, and this is what the liver actually will look like as we split through it. This right hepatectomy, again, a left hepatectomy, and this, what would be left. This is the right side of the liver, so that would be what would remain after the left side comes out. This is a more central tumor, right? It sits right in the middle of the liver. So in this case, what we like to do is to do what's called a parenchymal sparing or a middle hepatectomy. And so you'll see the tumor is out, and the middle is out, but we've left the left and the right side in there with the blood vessels still intact. A right hepatectomy is basically the other side, the opposite. We can take tumors that are pretty big out with resection as long as the rest of the liver is okay. A lot of times we'll be able to do laparoscopic or robotic operations. And so obviously you'll need to go to someone who has a lot of experience doing laparoscopic liver resections. And then we talked a little bit about, extending what our surgical resection abilities are. So we'll use portal vein embolization that we talked about. It makes the part of the liver that's going to stay bigger. And, it actually really helps with resectability. It increases the chances. And, sometimes there is evidence that giving chemo before liver resection or before transplantation will actually get people to within criteria. I'm not really going to talk about some of the more advanced liver resection techniques, but you may hear about those in terms of like ALPS or an XVO that I kind of alluded to earlier on. More about chemo or Y90, right? Take a tumor that's really very big and give either chemo or what's called transarterial chemoembolization. So getting chemo directly to the tumor or getting radiation directly to the tumor, that not only shrinks the tumor, but helps the other side get bigger. And so we can do that before resecting it. And what to expect after liver surgery. So everyone has some sort of morbidity, right? Whether it's what's called a pleural effusion. So it's kind of a reactive collection of fluid in the chest after a liver resection. Big liver resections, we have to peel the liver off the diaphragm, and so the other side of the diaphragm gets irritated and fluid collects. People can develop pneumonias because of the big resections, and you can't really clear your lungs very well. Up to 10% of people have some sort of bile leak. Depending on your surgeon and on your surgery, you may have a drain put in to detect those bile leaks and try to fix those bile leaks before it gets problematic. Very, very rarely, less than 2% of the time, there is risk of liver failure, which means the INR, so the coagulation gets worse, the bilirubin goes up, and of course, there's always a risk of tumor recurrence. Mortality is very, very low in terms of liver resection, and it's very related to age and liver disease and other kinds of diseases, whether it's kidney, pulmonary, lung, or heart disease. But I think that what we really need to do is have an honest conversation about what the likelihood of risks and benefits are before a major operation like this or a liver transplantation. What do we do in terms of monitoring patients? Labs all the time, and then alpha-fetoprotein levels to really measure whether there's any tumor leftover or any tumor recurrence. For transplantation, sometimes we use what's called cell-free DNA, which is a new thing, and maybe in liver transplantation it's going to take off, but the jury's still out. There's circulating tumor DNA that people are looking at. Again, these are more sort of investigational at this point, but anyone with cancer is going to have lifelong follow-up for recurrence, lifelong follow-up for liver function, lifelong follow-up for whatever liver disease that it was that got them there. And then, I think that it's always important to make sure that you follow with your doctors, whether it's a hepatologist that's following you, or your gastroenterologist, or your primary care, just to make sure that your liver is being taken care of. A little bit about transplantation. We talked about most liver cancer is multifocal. It's multiple different places. Taking the whole liver out is really the best cancer operation because it gets rid of the diseased organ with the widest margins. Transplantation is the only way to treat the cirrhosis, and it gives you back your normal liver function. And we do it for a lot of different things other than liver cancer, other than hepatocellular carcinoma. There's indications for neuroendocrine tumors and cholangiocarcinomas and other tumors. And there are places that even do it for colorectal mets. I'm not going to get into that right now. But I think the indications for liver transplantation are getting wider and wider. I'm going to finish with some new developments. I've been using a lot of fluorescence in my operations. It really helps identify tumors in the operation. This is basically what it looks like. The tumors get highlighted green as I'm operating on them. It helps me with margins. It helps me identify these things. And so, I think the technology is getting a lot better. And I think that, we're getting better as a team in terms of what we can offer to our patients. And there's some indication that the fluorescence actually is a good marker of sort of how bad the tumor is itself. So just as a summary, liver cancer, HCC, must be really properly staged before a whole treatment plan can be done. Again, this is what we talked about. This is the whole team thing: best imaging, best medical assessment, best liver disease assessment. It's a team thing. And so, and everyone needs to be individualized. We need to really take a look at individual patients to optimize their care. There's transplant, there's no transplant. There are other options: resections, non-resections, clinical trials, palliation. And so early referral, going to a center that is, that's what they do, is very important. And a multidisciplinary approach is key. And I'm happy to answer any questions.